everybody. Dr. Jiao is going to speak tonight. And I just wanted to tell you that Dr. Bourgeois, one of our cardiologists on staff, I wrote it down because he told me what he was going to do. He's going to speak in December on his title, Diet and the Prevention of Heart Disease. But in the back we have our, if you have any ideas and how do we do, if you have any thoughts for next year's, because please give us some thoughts on that so we can start that, putting that in process. Dr. Joe, you on?
December 5th?
Yes, it will be.
First, thanks everybody to come here, and how's every day? It's good?
Good, good.
So we talk about a lot of A-Fib treatment, anticoagulation, medical treatment for A-Fib. So I think cognitive function, we never have a chance to talk about that. And it's a very interesting topic recently, and a lot of things in this area we do not really know because a lot of questions and a lot of answers may be needed. And currently, this is a very real research focus on the neuro and AFib situation. So recently I read some expert consensus in 2018 and see what's the topic about the neural functions related to the arrhythmia. So probably take me about 20 to 30 minutes to finish the whole topic tonight, and if we have any questions, please just ask me. So today's topic mostly focus on three areas. Is what the terminology and etiology of the declined cognitive functions. Because this is the A-Fib topic, so I want to see what's the atrial fibrillation with the cognitive dysfunction, and what's the potentially mechanism background for that. And beyond the atrial fibrillation, a lot of patient here has any other cardiac arrhythmia conditions. Is there any related to them too? And what kind of the risk with the procedures? After you do the procedure, like we do ablation, is there any possible have any neural deficit related to that? So this is my major topic. Is it okay? You can hear in the back. So the terminology of the cognitive function, this is the neurologist topic, and I just find some definition online. So usually they use a standard cognitive test score to see the regular age, gender, the matched conditions. So if you have a greater than expected decondition from your score from the test, then they think you have a decline. The serious part of this cognitive function is dementia. So if you have a 2 or more than 2 cognitive domains that representative a decline in the previous level, so you compare by yourself, of the function, and severe enough for your daily life, then it's called the dementia. So between this, there is a mild cognitive impairment. So this is the 3 definitions when we talk about the cognitive function. Average in the West country, like the United States, probably 5 to 7% population will develop dementia if they're older than 60 years old. So Latin America a little bit higher, 8.5% when they are older than 60 years old. Sub-Saharan area is lower, 2.4. I think this is probably depend on their development, nutrition, lifespan situation. Their lifespan may be shorter, so this is why their percentage is lower. So worldwide in 2010, the data shows they already have 35 million people with dementia. And it's the number will be doubled every 20 years. So the project is in 2030s, there will be 65 million and there will be more than 100 million in the next 40 years. So most of this dementia actually happened in the low or medium income country. So this is probably related to a lot of reasons: cultures, geometries, health cares, and the nutritions. So this is just a slide that shows some, it's very small, I will probably explain it a little bit. This is the selective risk factor for dementia. Some things you cannot modify, such as your age. We're getting older, so if we're getting older, then the dementia rate will be increased. Second, we cannot choose is this gender is female actually is higher than the male. That was a little bit surprised me. Looks like everybody, lady is taking care about the gentleman or whatever I see in the hospital. And ethnicity is black people has more vascular related dementia than the white people. So this is all the things. The other thing, they have a genetic test, they have a genetic factor. So all this is we call the non-modified risk factor. You cannot change it by us. The other thing is a lifestyle factor. So if you have a high education, and usually the risk for dementia is low, especially the risk for vascular disease is lower in the high education population. Wow. So if the patient get lower education, the risk for vascular disease, stroke, like a stroke, TIA, because I think they probably have other risk factors like there may be less physical activity, obesity, more uncontrolled hypertension or diabetes. So that is probably contributing to that. And the physical activity, that's true. If you have less physical activity or rest most of the time in the chair a day, then your risk for dementia, Alzheimer will be higher, and that's its reason. Body mass index, that is the U shape. That means if you overweighted or what do you call the less standard weight, so it's like a U curve, too low or too high, your risk for dementia will be increased. So the body index should be kept in the normal standard range. Smoking is also a risk factor. If you continue smoking, then the risk for dementia will be increased. And after you quit the smoking, the risk of dementia is relatively decreased. And social support. If you have more social support, family support, then if you talk to more friends frequently, then the chance for dementia will be also relatively low. So the social work, social network put a lot of risk for the developed dementia. Other topic we call cardiovascular risk factor like high blood pressure, diabetes, high cholesterol. All this is related to the dementia. They increase the risk. And the clinical neurology damage by like a TIA, mini stroke, or stroke also increase your risk for dementia. The other thing is sleep apnea. So this is why we always in the clinic, whenever come in with AFIB, we ask whether you have sleep apnea. Sleep apnea not increase your risk for atrial fibrillation, also increase your risk for dementia. So the CPAP treatment, complying the BiPAP treatment, CPAP treatment is very important for this situation. Is speed okay? So this is probably for most of the neurologists, this is the different standard score, screen test, or more complex test to evaluation. What's your neural function? So this could be your memory function, your language function, your construction function, executive function. So this is all the topic they try to do. And usually they give you how many minutes you finish. Usually probably from 1 minute to 20 minutes will finish the test. And some test is more like for the screening test to see whether you have risk, and more is more particular on some functional test. I probably not talk too much about this. So this is a slide. This is the study in 2013, and you see the number is not that too much. It's probably control group only 90 people, and two different group is PXR is paroxysmal and PER is persistent. So totally about 270 cases, and they follow up in the different arrhythmia, like if you have A-Fib or not A-Fib. And you have an A-Fib is a come and goes pattern or constant pattern. So this is the three different groups. They try to compare the risk of the cognitive functions. So when you see the green line is the people do not have atrial fibrillation. They're all age and gender matched. So all the group is same. And the blue and the red is the blue is the paroxysmal, is come and goes pattern. And the red is the persistent. So you will see when you have an A-Fib, blue and red, and you have more cognitive dysfunction compared to people who do not have atrial fibrillation. So evidence suggests atrial fibrillation associates high risk of cognitive impairment, and probably relative risk is 2.4 times than the people don't have it, and the dementia probably 2.7 increase the risk. No matter whether you have a history or do not have a history of stroke or TIA, so it's an independent risk factor. So individual with atrial fibrillation but without stroke previously, the risk of dementia is modest. It's only increase your risk about 1.3 times. But if individual with atrial fibrillation and you have a history, previous history of stroke, then you develop the dementia will be increased to 2.7 times. So that will be significant depending on your previous history. Whether this is because the atrial fibrillation alone or is because of the dementia itself, because they share a lot of common risk factors, like your aging, your gender, people has hypertension, diabetes, sleep apnea, or chronic heart failure. So which one is cause which one? And they may be difficult to see A-Fib is the only reason, but they share a lot of common things together. And usually a lot of observed studies showed that A-Fib probably also an independent risk factor for the dementia. So this is why we have more focused recent years. There is a study called Eliquis study. This is a long study for totally probably 12 years. And they found if you have a persistent A-Fib, that means all the time you have atrial fibrillation, 100% atrial fibrillation burden with the cognitive dysfunction. But if you A-Fib burden with the monitoring only 1 to 6%, that means 94% you are in a normal rhythm, the risk for developed dementia is low. They did not find the risk factor compared to the patient without atrial fibrillation. The other studies showed subclinically cerebral ischemia area is higher in the individual with persistent one, atrial fibrillation compared to the proximal one. That means if you have paroxysmal atrial fibrillation, if they do the MRI of your brain, they find the stroke scar area is less frequently. But there is no random data. All this is observed small group Some cases report only like less than 100, some probably just more than a couple hundreds. So there is no random controlled data showed the efficacy of the therapy. Which kind of treatment? Medicine, or rate control, or ablation, or pacemaker with AFib node ablation? Which kind of the treatment is the best to prevent this kind of population to develop dementia? There is no answer for that, and nobody knows the correct method to do that. And how the individuals to modify this kind of treatment. You might be fit for medical treatment. The other patient may be fit for ablation. Some people have to do ablation and to keep normal rhythm. Some people use medication, can keep very well in normal rhythm. Is this two different people have the same risk for dementia or not? Nobody can answer this question so far. So this time we talk about AFib ablation with silent stroke. Silent stroke means you have an imaging document with MRI or CT. You have a stroke in brain, but you do not feel it. Clinically, you feel normal. You do not aware the situation happened to you. But atrial fibrillation, the current study showed if you have atrial fibrillation, you probably has twofold risk to develop silent stroke, which document on the MRI or CT scan, than the people who do not have atrial fibrillation. Usually silent infarction is a microembolic, always formed in cluster, so that is multiple areas, it's not just single area. And are most prevalent in the front lobe. This is of executive functions, but it can happen in the different area of the brain, and if you have a different area, it will has a side effect with different functions. So the current data suggests a significant association between sinus infarction with developed cognitive decline or dementia. So we talked about Eric's study previously. Eric's study continually repeated the study of patients for 12 years with MRI. They found the cognitive decline only in the patient who developed incident sinus cerebral infarction. So only you have a silent stroke, then the chance will be higher than the people who do not have a stroke documented by the MRI for their 12 years follow-up. So if you have AFib, the observed large amount say, okay, they might be increased the dementia, but this smaller numbers population follow 12 years and shows that if you have no imaging documented stroke, their chance probably low. Then how about patient without stroke, but he has atrial fibrillation? So there is a meta-analysis data, but you have to, when you explain this meta-analysis, has to be careful because it's not a group-controlled study. It's just to collect all the different published data and to give you a results. So it's not accurate, but it's also give you some information. So this study involved 77,000 patients. During the follow-up, they find that 15% of patients develop atrial fibrillation in their lifespan. And this population, usually they found they have no stroke and normal cognitive function in the baseline. So they collect this patient, 15 of them has AFib but without stroke previously at baseline. So they continue to monitor for 8 years. During these 8 years, all these patients who has no stroke previously developed, 6.5 of them developed dementia. And they think atrial fibrillation is an independent risk factor associated with dementia. So the heart ratio is about 1.4. That means if you have AFib, even if you don't have atrial fibrillation, you probably still has a 1.4 times risk to develop dementia after. 8 years. And the other smaller study is called the cardiovascular health study. It's involved 5,000 populations without stroke. And 11% population develop AFib during the follow-up. And all these patients develop cognitive functions faster than the people who do not develop AFib during the follow-up. So the high-risk dementia was especially younger if your AFib happened less than 70 years old. So if you have a younger population, looks like younger, you have a more high risk for develop dementia. The reason for that is unknown. And next slide, we talk about possible the pathology mechanism for atrial fibrillation and cognitive dysfunction. So when you have AFib, the most risk we worry about is the stroke. So the vascular dementia is by the stroke is probably the most common reason related to atrial fibrillation. So if you have developed stroke, 10% people have first stroke will develop dementia after their first time. If you repeat has a stroke multiple times, there increase the risk, 30 to 40% chance you will develop the dementia in your life. The other reason is Alzheimer's disease. I briefly tell you what Alzheimer's is abnormal beta amyloid peptide. It's a chemical things deposit in your brain and cause the brain cells atrophy. So and cause the dementia. So the AFib is an independent risk factors to develop Alzheimer's. They thought probably AFib patient has an abnormal peptide built in the heart and cause this beta amyloid develop in the brain. So you have some chemicals material develop in the heart is abnormal, irritate some abnormal material develop in the brain and cause the brain damage. So this is the thought, but it's not confirmed with that. Also, this we call the AMP is called atrial neutral-uretic peptide. It's a chemical from the heart. It's caused a special kind of cardiomyopathy. And atrial fibrillation also causes the brain flow, the perfusion for the brain is low because it could be because the fast heart rate, you do not perfusing very well, or irregular heart rate, you not perfusing well. From the old study, we know whenever you have AFib, you probably lost 20% of each pump. If the normal people, we say, okay, you have a 100 cc's pump for one squeeze, then you only have 80 cc's pump to the perfusion the body when you have atrial fibrillation. It's just because the irregularity with atrium, you lost the atrial kick, so you lost the volume. So this is probably the reasons. So this is just a slide and show atrial fibrillation with the brain, the heart and the brain. So that means you have the atrial fibrillation and develop the dementia. They have a common things in the first line like age, hypertension, diabetes, heart failure, obstructive sleep apnea. This is the common things can develop dementia alone, either by heart or cause atrial fibrillation alone. And when you have atrial fibrillation, you increase your coagulant disabled, and then you have developed this clot and the thrombosis formed and cause the stroke, no matter it's a clinic stroke or a silent stroke. All this stroke will continue to damage the brain. And the other thing is all the body inflammation factors can cause atrial fibrillation. All these inflammation factors also can damage the brain, cause the dementia. And the other thing is the last one, I have no point, but the last one just show you the beat by beat variabilities and the heart volumes decrease and decrease your brain blood flow, and this is the reason for your dementia. So I just want to briefly discuss a little bit, because everybody has, from the previous topic, a lot of people are talking about the anticoagulation, still has a lot of questions each time. So I just want to briefly discuss a little bit, but not too much today. For the individual with history of AFib and dementia, these people are probably not taking care about them very well because they forget to take medication. So persistent use Coumadin, or we call it Warfarin, is only 16%. It's not too much. And even they use less, but as long as they use, and they associate decreased stroke. So even they have dementia, they have AFib, but if they can continue to use Coumadin to prevent the future frequent mini stroke or silent stroke, their death rate and dementia rate will be decreased compared to the patient do not take Coumadin. And the new anticoagulation medication like Pradaxa, Xarelto, Eliquis, they compared to the Coumadin. Current data shows they might have a significant increased risk for stroke, especially the hemorrhage stroke caused by the blood thinning. So compare all the current data, compare the new type anticoagulation medication to the Coumadin, the new antiarrhythmia anticoagulation medication is better than Coumadin. But later I will show you, if you cannot afford with the new anticoagulation medication, Coumadin is even better than the aspirin. So this is, I want you to aware of it. Always some people ask, oh, can I take aspirin because I'm worried of bleeding? Then I will show the data to support, no, aspirin probably not as good as you thought. So the adjust dose of warfarin can decrease your 64% of risk for stroke. If you use aspirin, we talk about 325 milligram aspirin, you probably only have 19%. It's a non-significant lower your risk for stroke compared to the warfarin 64. So warfarin, if you compare the study compared warfarin and aspirin at the same study, the warfarin is associated 38% reduction for stroke compared to aspirin. And the new anti-arrhythmia coagulation, like we talked about, NOAC is like a Pradaxa, Xarelto, Eliquis, something like. Compared to the warfarin, significant decrease your risk for stroke. And particularly because the significant reduce the hemorrhagic stroke compared to the Coumadin. So the brain bleeding compared the new anticoagulation medication and the Coumadin, the new anticoagulation is better. When we talk to Coumadin, the major things why they not give enough protect is because a very important topic is the timing in the therapeutic range. We usually keep Coumadin level, INR level at 2.0 to 3.0. But when you reach this 2.0 above and 3.0 below, is very critical. If you delay to reach the therapeutic range we want, the risk of stroke is increased. And especially a lot of diet, food can conflict with the Coumadin. So sometimes you maybe have a very high numbers and increase your risk for hemorrhagic stroke. But sometimes it's very low and not reach the therapeutic and increase your ischemia stroke. So this is why Coumadin is very difficult to manage, and it's individually person is response to Coumadin is very different. Some people take 1 milligram every day is good, and some people have to take 10 to 15 milligram a day. So warfarin therapy is a U-shape. This is what we talk. If you overexpose warfarin, then give you the bleeding stroke risk. If you underexposure, that means you're not treated enough and increase your risk for sinus infection. So the timing for therapeutic with Coumadin is very therapeutic. This is why some people, if we need quickly reach the anticoagulation target, we usually prefer to give the new agent than the Coumadin, because you have to take a couple of days to reach the treatment. So this is a meta-analysis for several studies. This is very interesting. I don't want to explain it. So compare, the first line here is compare the warfarin and aspirin. You will see the absolutely reduction for the primary prevention and secondary prevention. The warfarin is better than aspirin. And aspirin is better than you take nothing. But it's not too much. For the primary prevention, that means you don't have a stroke, you take aspirin to how much you can prevent. It's only 0.8%. But if you have previous stroke, you use aspirin compared you do not use aspirin, probably give you 2.5% of adhere, 2.5% a year. But if you compare the warfarin and aspirin, if you do have a previous stroke, if you take Coumadin or warfarin, it will give you a 7.0% protection compared to the aspirin. So this is why we use the CHEST-2 score to calculate hazard risk. If you have any risk with score above 2, we do not suggest aspirin, no matter whether you worry about bleeding or not, because aspirin increases your risk for bleeding but not give you enough protection for stroke. So if you compare the benefit and the risk, actually aspirin is more high risk than you take the Coumadin. And the other study is, the next study is the analysis, compare the stroke and ischemia stroke with the new agency to the old agency. It's all show, the data show is the new agency prevent stroke, especially the bleeding stroke is better than Coumadin. So we all know there is a lifestyle changes might be improved or prevent the A-Fib. So quit smoking. If I quit smoking, decrease alcohol consumption, control my hypertension, diabetes. I use CPAP with sleep apnea. I lost my weight. Is that help me to prevent A-Fib to happen, or will help me to prevent to develop dementia? The answer is, for so far, is possible. There is no clear answer for that. But we still suggest everybody to do that is because observed studies show the benefit, but the long-term controlled study never started. So the true answer is unknown. Whether we need to do some gene tests to see whether I'm at risk for that or not is still debate, because we do not know what kind of gene deficit is contributed to what kind of atrial fibrillation for a particular individual. So there is a lot of questions need to be answered, and whether I need a medication to control my A-Fib, or I am the person better to receive ablation than the medication, there is no answer for that. So then we talk about A-Fib and with the dementias. Then there are other topics talking about if I have pacemaker, what are my chance for this situation? And if I have a cardiac arrest, what are the situation? So this slide is talking about cardiac arrest. So when you have a cardiac arrest, it depends on which situation you have a cardiac arrest. Is it happened in hospital, or is it happened out of the hospital? So the result is totally different. The outcome is very significantly different. So the brain damage in the cardiac arrest survivor is probably reported between 35% to 100%, depending on which category, which function test you use, which is it memory or is it functional or movement. The language is depending on which you calculate. And limited attention span, personal disturbance, movement disorders, dementia is all possible after the cardiac arrest. Memory loss is the most common, probably 64–65%. And also it has executive function, language dysfunction, and perceptual dysfunction after cardiac arrest. So, but the study showed that if you gain your consciousness after cardiac arrest, less than 3 days, your recovery is better than the people who continue in coma condition more than 7 days. That makes sense, because you quickly gain the brain with oxygen, nutrition, so your function will be recovered better. But if you have a severe cognitive impairment early on you wake up, then the long-term permanent memory and the motor impairment is significant. So it's totally also dependent on when you wake up and what your function is. If your function bad, then the long-term probably worse. Hypothermia is when we have a cardiac arrest. Most of the patients with a cardiac arrest with ventricular fibrillation, we go to low temperature. We call the hypothermia treatment for 24 hours to 48 hours. All the studies show that hypothermia treatment can decrease the mortality rate to 50%. And the neurologic deficit could be significantly decreased too. So this is why you will see a lot of patients in a CCU or ICU get the cooling treatment first, before we evaluate whether the patient needs ICD or not. How about device? A lot of patients get ICD, get pacemaker completion. So when you have a bradycardia or you have an AV conduction block, your heart rate is very slow, then the brain perfusion will be low. So a lot of patients has a memory loss, has a confusing with the slow heart rate. So when you put the pacemaker and improve the situation, improve the blood perfusions, so you will improve your cognitive function. So the pacemaker helps. And if you have a heart failure and you have a low perfusion in your whole body, include the brain, then we have a treatment we call the biventricular pacing. It's called synchronized therapy treatment. It also should improve the brain function after you put the bi-V pacing. And how about ICD shock? A lot of patients has ICD and get a shock, and they said, okay, the shock, after the shock, and 30% of people has a memory dysfunctions and cognitive dysfunctions, but usually improve after 3 to 4 months follow-up. So the long term probably not that long. And the psychiatric factors maybe also contribute with their problem. How about ablation? A lot of patients here probably receive ablation sometimes. And if you have atrial fibrillation, and if you receive the catheter ablation for atrial fibrillation, compared you do not receive ablation, the observed study said your stroke outcome is the same things with the ablation. But this is just observed. This is not the we call randomized clinical trial. So this is, you cannot trust too much, but it give you some concept for that. This is wrong. Alzheimer's disease, senile and vascular dementia is lower than A-Fib with ablation. It's not without. I mean, should be changed that. It's with ablations. The acute developed stroke during the procedure probably less than 1% related to the procedure. And some data showed there also has a senile MI imaging document stroke after ablation, especially you use radiofrequency catheter ablation, we call it heat ablation, compared to the cryoablation. So sometimes they said the acute event for paroxysmal to persistent may be 27 to 28% after the ablation. For SVT, probably 30%. But after 3 months follow-up, the cognitive dysfunction improved. So the A-Fib probably only 13 to 14% has some kind of dysfunction with the brain and only 3% with SVT. So this is related to the ablation itself. So the long-term outcome for the patient with A-Fib patient received radiofrequency catheter ablation, or the patient without history of atrial fibrillation. So the red bar is a 1-year follow-up, and the blue bar is the 3 years follow-up. So you can see the left side is no atrial fibrillation. The middle bars is the atrial fibrillation population, and the right side is the atrial fibrillation patient received ablation. So all the patients receive ablation compared to people with AFib, but do not receive ablation. The Alzheimer develop silent dementia, cerebral vascular accident, and vascular dementia is all lower than the people without receiving the ablation. So my last slide will be, because everybody when we're getting older, we will receive different kind of procedure, and how much risk related to the procedure, we develop the stroke or mini stroke. So AFib, after AFib ablation, probably 8 to 18%. The patient has a mini stroke or stroke. Coronary angiogram or PDC or stents, 11 to 17%. Coronary artery bypass, 16 to 51% develop the brain damage. Surgical aortic valve replacement, like a mechanical valve or ball valve valve, 38 to 47%. How about the new technology with catheter transthoracic valve replacement is very high, 68% to 90%. How about I have a carotid stenosis, I need surgery for that? It's probably 34%. And if I put a carotid artery stent, 15 to 67%. And angiogram, probably 11 to 20%. And endovascular aneurysm procedure, probably 10 to 60%. And even the left appendage clip or device, closure device for AFib, we do not do it here, but some clinical trial benefit the patient who cannot take anticoagulation, but their risk for stroke is high. We usually suggest them closure the left side appendage. But even with this procedure, it also has a high risk. This is the smallest study I just found that is only 23 cases for this closure device that have reported 50% stroke related to the procedure. So this is my topic today, and any questions?
Last topic you touched on, I had the left atrial appendage in 2008 in Tulane Medical Center. They said I didn't have to take Coumadin after that because it reduced my risk of stroke.
That's true. For the closure, I don't know which procedure. Probably at Tulane that time they give it take appendage with surgery, right?
It was a mini-maze ablation.
Mini-maze ablation. There is no long-term compare mini-maze if you take the appendage out compared to the without taking the appendage out. But we know in the history, if the 90% of the stroke from AFib is from the appendage. it's confirmed the study from the TE. Usually they find there are clot there. So 10% clot, not from the appendage. So you still have a risk to develop stroke, but the chance will be low.
You said
If
90% reduction in change?
There is no data for that, actually, because we know the risk for the appendage clot is 90% to develop stroke. This is we know. 10% of the clot is not from appendage itself. So if you take them out, then potentially it could be decreased significantly. Maybe 90% because you 90% take out. But the problem with this is Watchman is a closure device to closure the inside the heart of appendage. The risk of stroke still there, but is equal to the comedy. That means it's not 100% decrease of risk. But if you take the closure device with Watchman, then the risk for future stroke probably equal you take comedy. Comedy, you see the data probably give you 60 to 70% risk reduction. So I think this still has a Watchman. They put on Watchman, patient still has a stroke.
The range that you want to keep a person's blood in, is that different for everybody?
No, if you use the international numbers, it's 2.0 to 3.0 everybody.
It's what?
2.0 to 3.0 for everybody. It's the same. That is only used for the comedy when we talk about use Warfarin. For the new anti-arrest medication is different. Everybody is almost the same dosage unless you have some criteria, like if you age more than 80, or you have a weight less than 60 kilo, or you have a renal dysfunction. So you have 3 problems, and you have 2 of these 3, then your dosage for new anticoagulation will be decreased. So like Xarelto, you take 15 instead of normal people 20. Eliquis, you take 2.5 twice a day instead of 5 milligrams twice a day. Any other questions?
Could you go back to the slide that described the different kinds of strokes? It's about 3 slides back.
This one?
No, I think it's further back.
3 different size stroke.
It described it mentioned 3 different types of strokes. I was going to ask you to talk about what the difference was between of what those strokes are.
Oh. Stroke, usually we have 3.
Vascular stroke or
What you don't have stroke, right?
Right.
But if you have a stroke, there is one we call the silent stroke. That means you have imaging study show you have stroke, either MRI or CT scan. But you function well. You do not know the event when they happen. This is only imaging study. The other stroke is a clinical stroke, either TIA or significant stroke. That means TIA means in 24 hours, your symptom improved. It's disappeared. But if you more than 24 hours, then you have a stroke. So this is the definition for the different.
But it said hemorrhage.
Hemorrhage or stroke, you have depend on the pathology things. You have ischemic stroke. That means you have clot to block the blood flow.
Okay.
Or you have a hemorrhagic stroke. That means you bleed in the brain. Your
And the last was a vascular, I think?
vascular, yes.
Yeah. How is that different than the ischemic?
Oh, this is beyond my knowledge, to be honest with you. But I think personal thing is hemorrhagic stroke is more depend on the size. As I know from the knowledge neurology teach me, they do not like hemorrhagic stroke than the ischemic stroke. It depends on size, location, It's always that. But if you have a large area hemorrhagic stroke, usually they do not want me to resume anticoagulation, even your risk for ischemic stroke is still high. Because they said if you have a big stroke, even your function will improve, but if I give you anticoagulation again in the future, then potentially your risk again in that area is high. So it's a very bad scenario. The patient has A-Fib, but they have a hemorrhagic bleeding, either by themselves or by the blood thinner. Usually in that situation, they do not allow me to resume the blood thinner after bleeding in the brain. So in that situation, I usually suggest my patient to consider the closure device.
Is there any difference, are you aware of any difference in the stroke risk with the new medicines or the anticoagulants?
New medication is better than Coumadin. Coumadin is better than aspirin, and aspirin is better than nothing.
When you say an aspirin, you're talking about 81 milligrams of aspirin?
There is no dosage with that situation. Actually, the old study is used 322 or 325 milligrams. So we talk about aspirin, we're talking about aspirin 325 milligrams. But there is no study compare 81 is if take the same effect compared to the 325. There is nobody compare that. In the prevention for A-Fib, there is no study for that.
Those new anticoagulant drugs have an antidote if you start bleeding.
I think Pradaxa has it and Xarelto has it.
Eliquis too. Eliquis and
That's already
Xarelto's is
on
the
now?
same thing.
Oh, okay, you can use him. So now you have Eliquis. Yeah, Eliquis, Pradaxa, and Xarelto they have it. Yeah. But do we have this in the hospital?
We have the Praxpine in the hospital. We don't have the other one.
Okay, so we only have for Pradaxa one. So it's dependent on the hospital pharmacist.
It depends if they have the antidote.
Yeah.
So which one do you all have?
We have
Pradaxa.
we have the one for Pradaxa. It's extremely expensive.
Extremely what?
Expensive.
Any other questions? Any suggestions for our topic? We want your ideas because we almost run out of the ideas. I don't know because this topic always continually. Any interesting topic you want to hear, or we can ask some people, physicians, or PAC to come here to talk with you guys on different topics. That would be great.
What if you take Exaltin, Exi, and it
Xarelto?
makes you worse?
A reaction.
What kind of
Reaction.
What kind of reaction?
Hyper.
Sensitivity, you mean the allergies?
No, just it makes you feel worse. And
I think you can try the production because it's different category. Eliquis, they are the same chemicals, just different company.
okay, the Exaltin do not work.
If it let you have side effect, I usually change production because it's targeted a different area and it's different chemical.
Because it was worse. It made things worse.
What kind of worse? You mean the bleeding? You mean your anxiety?
Anxiety.
Usually
This
GI issues, yeah. If you have a GI issues, then you can change different.
Let me ask you a question. I was on Pradaxa. When I had my heart attack, they took me off Pradaxa, put me on Eliquis. Do you know what the reason would be for that?
I don't see the reason why they have to change. I personally don't think so. There is no head-to-head compare Pradaxa better than Eliquis or Eliquis better than Pradaxa. They never do that. And for me, recently we think you use anticoagulation like Pradaxa with one of antiplatelet, like a Plavix or aspirin, probably good. In the old time, we used two antiplatelet, like Plavix, aspirin, and combine either Coumadin or Munich anticoagulation medication. the risk for bleeding is high. And now in the last couple of years, more and more data shows you do not need 3 regimens after you have an acute heart attack, acute stent situation. Probably 2. One is anticoagulation, if you have to take it, and 1 antiplatelet, probably good enough, and significant decrease of risk for bleeding.
I had to ask my cardiologist when I go back to
It's probably the personal choice. I don't think there is any fundamental science different.
she put me on it, and I don't know who took me off of it, but Eliquis, when I came out of the hospital, I was on Eliquis then.
I think this is probably more personal choice than the true science choice.
Is there, with Eliquis, because I had the 100% blockers on the left side and 50 on the other side. They put a stent on the left side, and there was somebody, one of them, I thought I ever heard somebody say that the Eliquis would,
What's better with other medications?
was better with other medications or plastics or, I don't know, but I'm on both.
You probably ask me that personally.
Yeah, we have to.
From the anticoagulation and antiplatelet standpoint, I do not see the difference.
Okay.
Good question, but I see it on the 17th. Sure.
This is probably for personal choice. If you think about stroke prevention, Pradaxa compared to Warfarin, the brain stroke prevention is better than Coumadin. And Eliquis, Xarelto to prevent the stroke compared to Coumadin, they equal. But whether the Pradaxa to prevent stroke better than the Eliquis or Xarelto, you cannot see because they only compare with Warfarin. But you cannot compare Warfarin result to compare them.
They don't compare to each other.
Okay, thanks for coming.
Is it, can these slides be posted on the website? Because it's kind of hard to read it from.
That's fine.
I'll try to get
We
a
can put it
print,
on the website because
Yeah.
I put a slide there.
or I'll get a printout.
Print out?
Mhm.
They can put a
I
slide,
can print.
the slide, whatever. Yeah, we will try to do that. So you can read it.
Thank you.
You're welcome. Thanks for coming.
Is there a
Thank you.
risk for long-term use of the medication?
What?
Is there a risk for long-term use of the medication?
Good questions.
Or we-
I personally think, you're talking about anticoagulation?
Yeah, the Xarelto and the Eliquis and etc.
It's totally depend on the side effect related to the, if you have a micro bleeding with this all kind of anticoagulation, the answer should be yes. But if you do not have this situation, probably fine. It looks like Coumadin. If you have a renal failure and you're on the dialysis, if you take Coumadin and you prevent the stroke, but you increase the calcification deficit in your microvascular, and actually you take the Coumadin with the dialysis patient, the risk is for death is high compared to the patient do not take Coumadin. So then, this is why you talk about the renal doctor, talk about the stroke prevention in A-Fib with hemodialysis patient. They do not like idea for put on the Coumadin. But whether the new medication is good or not, there is no study for that. Because usually all the clinical trials, they try to choose perfect patient. They get rid of a lot of patients we usually see on the daily basis. It's not involved because they're high risk. They will not show the benefit for the medication. They cannot put the medication in the market. So the answer for the new medication with dialysis, nobody knows yet. So potentially could be, but there is no study to confirm it. Okay.
What determines the reason that you would have the ablation? Like if medications stop working and you were getting more and more A-Fib episodes? Or I'm just starting with this. Should I just be proactive and go right to the ablation and see
If you see the current guideline, okay, they always want you to try at least one medication We call it anti-arrhythmic medication for AFib.
Okay.
If you failed with the one anti-arrhythmic medication, and after that, the ablation is always, you can consider.
So I guess I'm trying to decide.
We do not suggest people just jump into the ablation. This is my practice. Is also supported by guideline. You do not want the patient jump into the ablation directly
You also have to be a good
without the
candidate.
medication trauma.
You also have to be the right candidate for it, correct?
Mm-hmm.
But you have to be a good candidate for it?
Yeah.
Not everybody.
Yeah, you have to. Yeah, it's not everybody is good candidate with that. Especially recent study, some studies shows the benefit for AFib ablation compared to the non-AFib ablation. Depend on which study you use. Some study don't show too much benefit unless you are less than 65% or unless you have heart failure. If you have a heart failure and then you have an AFib, then the result is better. And compare the people less than 65 have AFib and compare the people older than 65, some results say, AFib maybe not that good as we thought before. Usually, you're driven with ablation by three things. One, you develop stroke with AFib. Two, you develop heart failure with rapid ventricular rate during the AFib. Three is just quality of life. Some people don't have symptoms, then you can deal with that. But with today's study, if you live longer with AFib, the potential for dementia will be increased if you not stop it. But you still can live with that. But some people have symptoms, like 60% people has symptoms, fatigue, tired, memory changes, whatever, they cannot function very well. And the medication doesn't work, then we usually say give a try. And some people can have a good period of time. We have some people do ablation 5 years ago, they still maintain normal rhythm and they're functioning well compared to in the AFib.
Age is a big factor too, isn't it?
Age is, yeah. Age is probably the most important risk factor for AFib or anything else. And if you're talking about the recovery rate with AFib, then the hypertension control, obesity, and sleep apnea is all the risk factor with that situation. Okay, thanks.
Thank you.
Thank you.